Good morning, and thank you all for joining this session of the North Country Leadership Summit, Emerging from a Year of Change, an opportunity to rebuild and reimagine. The summit is brought to you by Adirondack Health Institute and Fort Drum Regional Health Planning Organization. We want to highlight and thank all of our sponsors for this year's event. Thank you to all of our sponsors for the continued support. Without that support, we wouldn't be able to host this event. So thank you again to all of the sponsors. And finally, some housekeeping items. Please place any questions in the chat box and we will make sure that those are addressed throughout the presentation. All attendees, please remain muted and your video off to ensure the best broadband and reduce any distractions. And finally, all presentations are being recorded and will be archived on the Leadership Summit webpage by the 1st of October. With that, I'd like to introduce our presenter. Today we have Brian Justice from Excellus, BlueCross, BlueShield, presenting on a unique collaborative community health initiative using back pain as a catalyst to change. Brian, take it away.
Good morning, everyone, and let me see if I can bring my slides up for you. Okay, and again, which screen are you seeing now? The full screen or the presenter screen?
The presenter screen.
Okie doke. And now?
Looks good.
All right, thanks. Thanks, everybody. I'm honored to be here, and thank you for joining us today. I want to talk about a unique collaborative on community health. You know, so often community health issues are based around high blood pressure or diabetes, and I'm going to make the pitch that back pain might be an intriguing way to look at community health initiatives. And I'll show you with the infrastructure that we built at Excellus, how we vetted it across the country, and how we're implementing this idea in Binghamton right now. And we're really looking to bring this idea of back pain as a community health initiative throughout upstate New York. So I'm going to take you through, I'm going to tell you a little story at the beginning about two identical twins, review some of the current challenges in healthcare that spill over into spine care, tell you about our spine health program and how it's designed to kind of attack some of those challenges that we see. Just a quick discussion about how waste can become harm, and then the important discussion of spine pain as a springboard into well-being and wellness care. And then we'll wrap up with, is there a way to address this from a community perspective and start to create maybe a compelling vision there that might intrigue some of you to explore it further with us. So let me start out by telling you the hypothetical story of two identical twins. This is actually a paper that we just submitted for publication in a peer-reviewed journal. It's hypothetical. These are identical twins having the exact same back pain on the same day. But these scenarios that I'm about to give are really consistent and very common. So we have Bob who has back pain, hurts his back on Monday. Calls his doc up, his primary care doc says, come on in tomorrow. He's busy on the internet that night. He comes in saying, well, I'm in a lot of pain. I did my homework. I know I need an MRI to see what's going on. I need an opioid to control my pain, and I need to see a surgeon to get this fixed. And I'll be talking about how I've done these workshops with hundreds of primary care docs throughout upstate New York. And it's not unusual, even in a room full of their colleagues, that they will say, I have to admit, on a busy day, I do those things. I just say, okay, and write those 3 scripts. And here's what happens when you start the care pathway that way. And that is that Bob now goes home, starts taking his opioids, waits a few days, gets his MRI, sees his MRI report on his patient portal, sees all this scary language. He's sitting home in his recliner, focusing on his pain, worried about it, then sees degenerative disc disease and facet arthritis, which continues his worriness. Oh my gosh, I have a degenerating back. He has to wait 6 to 8 weeks to see the surgeon. He gets in to see the surgeon. The surgeon says, sorry, Bob, you do not have a surgical case. Bob's angry at the surgeon, angry at the primary care doctor. He's been out of work because work doesn't have any light duty for him. They only want him back when he's 100%. And he's been home thinking about his pain. And what happens when you're inactive and thinking about pain is that this thing called neuroplasticity kicks in, where it's almost like bandwidth, where your brain starts paying more and more attention to pain. And to make a long story short, we are really progressing Bob along the path of chronic pain. In fact, this is one of the best predictors of what acute back pain patients are going to become chronic are if they had these three, the MRI, the opioid, and the surgical referral, made too early in the course of care. I mean, this is really some groundbreaking study that just came out a few months ago that was published in JAMA that showed that the things we knew that would predict what acute back pain patients would become chronic, how do we prevent the BOBs? We knew that things, and this study reaffirmed things like comorbidities and previous history of back pain. If you're a smoker, overweight, though not too much, but weight does play a role in it. Do you hate your boss in relationships? Are all play a role here, but the strongest predictor are the actions of the first contact practitioner. And if they did these three things, that's the best predictor of what acute back pain patients becoming chronic. In other words, we as a system are driving people and we're creating chronic back pain patients. Now let's go over to Gary. So Gary, it's his twin brother, same thing. He goes in to see his doc, who's also very busy, but his doc's gone through some pathway training. He now understands a concise, meaningful history. He doesn't spend really more time with Gary, just more efficient time with Gary. He knows how to go through a functional pain reproducing examination, which helps for Gary to understand what's going on, for a clear diagnosis and care plan that's going to be patient engaging and active. And that if he can return to work and return to activity, a light duty option, or the importance of movement and activity are so important in early recovery. And lo and behold, even though these identical twins had the same back problem, Bob has now chronic pain. Gary resolves in days or weeks. So we further drew this up by rather dramatically saying that Bob got sucked into the dysfunctional care vortex. A vortex of a healthcare system that is really patient passive approach. There's no consistent pathway, and there are obstacles to patient access, as compared to a very supportive healthcare system where the appropriate intervention early on means only 2 or 3 steps to get resolution, because it's patient active, because it's evidence-based, because patients have access and the providers in the community are engaged in the same pathway. And so you may be thinking, well, okay, but I mean, how common is this really? And so here's 3 studies that exemplify the challenge on the clinical side, and that is that Rachel Bookbinder a few years back published an intriguing article that showed the primary care providers who are the most confident in their approaches in spine care are the least evidence-based. And so the people who need to listen to make changes are the ones who are least likely to pay attention. The Stevens article in JAMA was the one I just referenced, where the biggest catalyst of driving from acute to chronic are inappropriate imaging, opioid, and early special surgical referral. And then this last study by Camper that was in pain a couple of years ago, or last year, showed that only 20% of the time when you have back pain are you getting evidence-based care from a typical primary care doctor. So there's a lot of confusion out there at the primary care and early contact provider level. And it isn't just the physicians. There's high inconsistency at all levels of spine care. And it isn't just the clinicians. It really takes a village to create this, Bob. There's roles that insurers play, hospital systems, employers as well. And that's why the importance of community comes to the forefront. And we'll review this before we go. And this study just came out 2 or 3 weeks ago. And I wanted to throw this, remind you of how, embarrassingly our national healthcare system is. We spend the highest proportion of our gross domestic product, but we still rank last overall in providing equitable, accessible, affordable, and high quality healthcare. And they look at these 5 domains: access to care, care process, administrative efficiency, equity, and healthcare outcomes. And by the way, we've consistently ranked last for the last 7 editions of this report dating back to 2004. The study went on to say that our system delivers too little of the care that's most needed and often delivers it too late. And you're going to hear me talk a lot about the importance of going upstream with care. And what does that first contact provider say and do? How much do they engage the patient? What tests do they order? Do they understand a biopsychosocial whole person model of care? And then the last part of the study was that we need to target the factors that go beyond what many people consider healthcare, and that is the power of education and childcare and community safety and housing and nutrition, transportation, workers' benefits that really drive a healthier population. And we see these many of these things having a tremendous impact on spine-related disorders as well. So let's go up to 20,000 feet. And I know I'm preaching to the choir here, but let me preach if you don't mind. And that is that we're not spending our dollars wisely. What really influences health, and it's, healthy behavior, your zip code, your environment, 20% genetics, did you pick the right parents? And maybe 10 or 20% is all the other stuff we pay for. Those social determinants of health that we're all so focused on right now, as we should be, are really encompassed in that first 70%, but we're not spending many dollars in this area. We're not accessing this. We're not really influencing behaviors and environments of individuals. Again, can we go more upstream in what we're doing? Other issues that really impact the efficiency of our healthcare system is that we've created a very passive healthcare system where individuals seem to be abdicating their health to systems and providers and not to themselves. And University of Utah did this study where they ask by stakeholder these questions. Who's primarily responsible for health improving was one of the questions. When they asked patients that question, 45% of the time said, I'm responsible. 44% of the time said, well, my healthcare provider is responsible for my health. And I think we can all agree that in a healthy environment, we would like individuals to take responsibility for their own health and just work within systems to support them in recovery. But it's not there. And even more upsetting to me, or perplexing even too, was what this study found when they asked physicians, where 75% of the physicians said, I'm the one who's primarily responsible for health improving. Now, if you take on that perspective, it's no wonder that there's high primary care burnout, that there's maybe lower patient engagement, maybe there's more defensive medicine going on. And so again, I think we need to offload the physicians from this perspective, but this has to come from a community perspective. Other cultural issues we have are with opioids, and why in the world are you 30 times more likely to die from a drug-induced death in the United States than you are in Portugal? It's not like we have any kind of vast difference in pain-generating diseases here. This is a cultural issue. Why in the world, over the 17 years of this study, were there 25% more adults saying that they have chronic pain versus 17 years prior? By no coincidence, right in this time frame is when we started the Pain is the Fifth Vital Sign initiative, and that focus on pain by providers and communities and headlines, and that really created this culture of relief that we have in our country. And the irony here is that second study, where just seeking pain relief creates more pain. It creates this hypervigilance. It feeds that neuroplasticity I was talking about, that bandwidth issue I was talking about earlier. And so I'll be talking quite a bit about languaging and how powerful language could be. And I just want to throw this slide in there as an example of that. And that is that, the Institute of Medicine came out in 2011 and said, oh my gosh, 40% of US adults have chronic pain, made all the headlines. And, what do we do about this problem? Which was, of course, way higher than any other country in the world. And so now what happens if we just change the language, if we just change the definition? So what if now we talk about high impact chronic pain, which is not just how often do you have the pain, but how often does this pain limit your work or life activities? Well, now if you put that functional component with the pain, only 8% of adults meet that criteria, which is much more palatable, much more manageable as compared to dealing with almost half the population. And it shifts the focus to active care and functional care and quality of life, and not so much on pain suppression. It also changes the focus of research and policy and pain management approaches away from just looking at the pain toward how do we impact and improve the quality of this individual's life. I think this study really drives home that idea of passive care. And this was from the Journal of the American Heart Association. So I'm going to, jump away from spine for a second and tell you that this study, they were surveying 40,000 middle-aged cardiovascular disease-free individuals. And during the course of that study, 8,800 of them were started on antihypertensives or lipid-lowering meds. And lo and behold, by the end of the study, what happened? Those who were put on the meds, their BMI increased and their physical activity declined. Right? This is the exact opposite of what we would want to see to treat both of those conditions. Why did that happen? Well, I'd like to put the premise forward that the individual abdicated their health to the pill, that they didn't take personal responsibility for it, and that when we only focus on a subset of a disease, how we can have spillover effects. If we focus on a passive approach to a disease only, say diabetes or cardiovascular disease, and we get those clinical numbers better in that one area, but we're not addressing the lifestyle issues, these comorbidities, which are almost always present, are going to get worse. So how do we counter our passive healthcare system? Well, we need active patient engagement. And really, we as systems need to ask this question. And that is, does this person need to become a patient? So with back pain, that's often true because many times you have back pain, but you don't need to become a patient, but you don't know that because it can be a really painful and sometimes really scary event. And you're thinking, wow, I've never had pain this bad. I better go to the emergency room, which is often one of the worst places you can go to start a treatment of back pain. So, what can we as systems do to create environments where the body can heal? So it's not dependent on health systems or providers to just unilaterally healing this patient. And then how can we get providers and systems to understand that a pill or a procedure or a surgery should never be administered alone in isolation, but always accompanied by some supporting action? Get the patients engaged so that they have a sense of control of their own health and their own well-being. And, major institutions over the last 4 years have really flipped their premise. The American College of Physicians and Center for Disease Control, HRQ, JACO, and National Institute of Health have all come out with documents over the last 4 years, changing from their approach to spine-related disorders, which used to be try this pharmacological approach first, and that doesn't work, go to non-pharmacological care, and totally flip that to say, okay, start with non-pharmacological care first. So let me start to build the infrastructure of back pain, why it's a problem, why it could be used as a community health initiative, and what we've been working on in our pathway. One reason that it works as a public health issue is because it's so common. A lifetime prevalence is about 84% for back pain. It's about 30 to 60% for neck pain. And in the next 3 months, a quarter of adults are going to have some level of back pain. And it's also still one of the leading gateways to opioid use in the US. And I would challenge you to find any other area of healthcare where we're putting more money into it. Even our spend on spine is more than our spend in the rest of healthcare, but we're getting more disability out. So it just really just screams of inefficiencies. So where are those inefficiencies? Well, one of the things is high levels of variation. If you look in the right-hand corner, those charts are, this is just about spine surgeries. This happens to be BlueCross BlueShield data. Dartmouth has similar maps that you can go to they're equally as intriguing. But the idea here is there's huge variation of how often spine surgeons are doing surgery. And even in our upstate area, in the Excellus footprint, when we look at all of our spine surgeons, we see that when a spine surgeon decides to do surgery, do they do fusion surgery? Do they put a piece of metal in your back to really stabilize it? And some of them choose to do that 18, 19% of the time. Some choose to do that 93% of the time. So if you have that level of variation, you can't have quality. But that's also true with pain interventionists, physical therapists. Are they going to be passive or active in their approach? Chiropractors, you're really not sure what you're going to get when you walk in the door. And I already talked about the high level of variation with primary care. In fact, if you went to 3 spine surgeons and 3 pain interventionists and 3 PTs and 3 chiropractors and 3 primary care doctors, I doubt if you would hear the similar message from any of those. There'd be a fair amount of variation. To further complicate things is the grocery store picture in the bottom left-hand corner. Haldeman did this study where he equated a patient trying to figure out what to do with their back pain, like shopping in a grocery store, because he found 120 different treatment approaches for back pain, 24 different provider groups who are doing that, these different interventions. And I already mentioned high variation among those practitioners. So what's the probability of that patient having gone down an efficient path to feeling better? And that's why you get some of these big spend dollars that you see in the bottom right-hand corner. And again, that's just BlueCross BlueShield data. So this chart on the left-hand side, I used for permission from Stanford University. They had us out there to brainstorm with them as they were developing a spine care pathway and ask us to mentor their post-grad program in this area. And I really like this slide because it just shows the doctor shopping and the confusion that many people go through when they have back pain. And wouldn't it be great if we create a system where we could start streamlining best evidence and technology and data and give patients access to this streamlined pathway system? If we could do that, we would see less variation and higher value, which is higher cost, higher quality and lower cost. But we have to make sure that it's pathway supported, that patients can access it, that there are appropriate incentives to make sure this happens. And again, that communication piece is so very important. I was on a panel with the Washington Health Alliance, and I used this slide with their permission because I really, it really speaks to, oh, my apologies. It really speaks to the need for us as communities to start translating data and translating evidence into action. In other words, just presenting people with data alone isn't enough. Organizations, individual practitioners are so busy right now, they're not quite sure what to do with the data sometimes. Can we as communities, and can Excellus help with that, bring forward some data, help to translate that data, put it into a compelling story that creates conversation, that leads to behavior change, that really creates actionable steps that improve the health of our individuals, of our community, and our community as a whole. And this translational step, I think we all need to be engaged with, and I'll talk about the importance of collaboratives at the end. Sorry, hang on just a second. There we go. So before I go too much about our spine program, I think I have to create a little street cred. I have to tell you how hard we've worked on this and how we vetted this nationally. The people who have created this pathway have over 100 peer-reviewed journal articles, a lot of clinical practice, have helped develop some of the other spine programs in the country, including NCQA. It really started when we were asked to develop a spine care pathway for what's now one of the Bethesda Deaconess Harvard-based hospitals in Massachusetts. We published the data in peer-reviewed journal and published a few other articles on how the health system needs to realign when it comes to looking at spine care. And this kind of intrigued Excellus, and so I was a practitioner in the region for 28 years, and they recruited me out of practice to come and see if we could bring this through upstate New York. Well, interesting thing has happened, as we're doing that through upstate New York, there's been more and more interest about what we're doing nationwide. And so we've been asked to speak and support initiatives. The Pacific, or now the Purchaser Business Group on Health, is the largest healthcare purchaser in the world. And when they had us speak out at Palo Alto a few years ago at one of their summits, we were able to vet these ideas in front of the head of HR of Walmart and Apple and Microsoft and Google and Boeing and Disney and so many of the big companies around the world to see, does this resonate with you, this approach? We continue to present to the biggest spine societies in the world. The actual biggest is the North American Spine Society, but also we've presented to the American Board of Internal Medicine and the professional societies of chiropractors, physical therapists, and neurology, neurosurgery. When it comes to consumer-driven consumer reports, the last time they had a cover story about back pain, our program was the only one in the country that they highlighted. And that created a relationship that I'll talk about a little bit later. Academia, we continue to, I mentioned Stanford already, but we've also helped develop programs at UPenn and Rochester. UCSF actually said in a journal article how they built their program off the Excellus spine program. And now we are introducing and supporting Duke and Dartmouth in both the study and in the training of their primary care docs. Blue Cross Blue Shield Association has been very interested in our plan and has been creating environments for us to share it with other Blues plans, and other Blues plans are starting to adopt this. And then, as I mentioned earlier, we continue to publish in peer-reviewed journals. One of the journals is the European Spine Journal. I want to talk about that one. That we did not publish that one. That was an independent a group of clinicians who looked at all of the spine care pathways worldwide. And they had really rigid criteria of quality and access and feasibility and implementation. And they found 11 in the world that met their rigid criteria, but only one in the US. And the only one in the US that they found that met their criteria was ours. So let me tell you a little bit about the care pathway. We train providers in a best evidence biopsychosocial approach. We now have that training online. We started out doing it live, and putting it online, thanks to COVID, has really made it simpler for practitioners to engage. We have the primary care practitioners have a kind of a feeder pathway, a 90-minute version. Interestingly, when we put this version forward and looked at the data, and again, Dartmouth helped us look at this data, and we published it in the Journal of General Internal Medicine. We found a natural experiment unfolded when one of our aquas, which is like an ACO structure, one of our aquas said, gee, and this is when I was doing the training live, it's hard to get face-to-face time with primary care. Just train a subset of our providers. We're going to wait a year and see if it makes a difference. Well, a year later, we looked at that data, and those who went through our training, their per member per month or their downstream spine costs were 28% less than they were the year before. And the providers in the same aqua that did not go through the training went up 8%. So we had this 36% delta between the two. The 12-hour training is for any willing provider, but it's a full pathway training. It's been mostly attended by chiropractors and physical therapists, though we've had surgeons, primary care, PAs, nurse practitioners all go through it. We did look at the data specifically for PT and chiro, and those who went through the training, their downstream costs were 41% less. And then we've enticed this training because, one-time training alone, it needs ongoing support. And so now there's this free learning collaborative that is also available to anyone who goes through the training through Excellus, where we can support the stakeholders with a toolbox of ongoing language and shareable tools with patients and for their own education. And there's also things like they can bring forward trouble cases. There's a blog. There's an interview of thought leaders in spine, review of best evidence. And so again, can we support practitioners in this ongoing way? The pathways really supports all stakeholders. We can't make this focus. The problem with spine care is not about practitioners alone. It's about us as a system. And so can we still give patients the ability to choose, which is so important to them? And right now, when they choose who they go to, about 40% of the time, typically they see their primary care doctor. But in many communities, it's 35-40% of the time they may choose to see a chiropractor first. Physical therapy is on the rise, which is why we focused on those three groups. And we are just rolling out. Next year, we'll have training for the emergency department and urgent care centers. Who are those first contact providers? And again, what do they say? What do they do? How much do they engage the patient? And so the providers are finding, that they like this program because of its efficiencies that it brings, and higher satisfaction and more competence and confidence they have in the interaction. The employers, of course, like it because spine is the number one cost driver for them. Please remember that employers, not only do they have to suffer the consequence of direct costs, but they have the indirect costs of lost productivity and disability, which really makes the spine-related disorders of huge interest to our employer groups. And of course, the plans. It's really important that they stay engaged. That we as Excellus stay engaged to improve our member experience and build our relationship with our providers. And our goal is to bring value-driven healthcare, and which means we have to improve quality and at reasonable costs. So the program has been shown to be beneficial. It really helps to start standardizing the approach, the care approach through the community. when their first contact provider feels confident and competent in what they're doing, so 85% of the time, that's the only practitioner they need to see. But if not, through the pathway, they also know when is the most appropriate referral to which specialist and when. When should we wait a few weeks to see if it works, or when should we expedite those referrals? And those efficiencies are well received by the clinicians involved. We have shown, as I already mentioned, outcomes and cost reduction. And again, please remember that that's the data that we have. So, many of you might say, well, what about outcome measures? And we are working on that, and I'll show you how, but we've only been able to capture some outcome measures with groups that are willing to share that, but we're going to show you how, as a community, we could collect those down the road a bit. And again, my last pitch, and you hear me say this again and again, is that power of communication and a consistent message so that patients, providers, and employers and payers are all on the same page with the same motivating language and consistent approach to care. So when we go through I want to talk a little bit about the trainings that we take these providers through, and just give you a little feel for some of the things we talk about. And one is this power of expectation, and how as a clinician, if you are in a passive mindset, or what we call a pathoanatomical mindset, you think that back pain is from a boo-boo, it's from a tear or a rip or a herniation. Sometimes those are true, but most of the time there's complexities there, and how the individual interprets the pain, or how specific we can be in the diagnosis. And so if the provider or the patient, but if the provider finds the patient using language that is, they're disengaged with activity, I'm afraid to move, I don't want to leave my chair, there's signs of depression or fear avoidance, catastrophizing, oh my gosh, this is the same back pain my Uncle Joe had, he had 3 fusion surgeries, he's in a wheelchair now. And can we shift the language to more self-efficacious, so that there's active coping skills and they could confront the pain, the continuation of activity, so very important that work and activity are actually therapeutic. We continue to do this with languaging. We try to shift the languaging away from what we call a pathoanatomically based communication, meaning, again, that we can find a problem with your anatomy, and if we fix that, your pain's going to go away and you won't have back pain again. That's not how back pain works. And so, I was guilty of saying some of these things in practice earlier, and just by saying what you think are simplistic, just direct things from the provider. Like, oh, your MRI shows you've got degenerative changes and disc herniations and arthritis, and the patient's thinking, oh my gosh, I'm never going to get better. Or if you say there's nothing wrong with your back, they think it's in my head. Stop when you feel pain. Okay, activity must harm my back. You should be able to work. Oh, they think I'm faking it. Pain is normal for someone for your age. Well, that's great. I'm only going to get older, so I'm only going to get worse. What if we could tweak that language to a little more what we're calling psychologically based communication? With just subtle language changes, like your MRI doesn't show anything to worry about. Okay, good. Nothing seriously wrong with my back. Or the cause of your pain may not show up on MRI. Now, really, that says 2 things to the individual. One is that, wow, this practitioner thinks my pain is real, so I feel validated. And 2 is that an MRI isn't some magical tool that's going to diagnose my back, because it doesn't. You should increase activity as tolerated. Okay, activity is good for me. There are many things you can do on your own to control your pain. I can learn to handle my pain. That is a huge, huge lesson. And also in the training, we talk to the practitioners about how low value care or waste can become harm. And this is a real eye opener for some, because we can just show that, oh, it looks like you're taking too many MRIs, and they're going to say, yeah, okay. And if they don't see the literature and don't understand how it could actually harm their patient and what the detrimental effects are of an early MRI, there isn't much behavior change. But when we show them these things, there's significant behavior change. So in this example, this is one of our ACOs. We ran this data using the MedInsight Health Waste Calculator, and found that 2/3 of their back pain imaging was inappropriate. And this met with the Choosing Wisely initiative, which for some of you who aren't aware of it, it's an initiative with the American Board of Internal Medicine, where they challenged all the professional societies to come up with 5 areas of of waste within their profession. And so these 6 organizations all picked that inappropriate imaging in the first 4 to 6 weeks of back pain without any red flags, without any real signs of danger is inappropriate. And here's why they thought that. And that is that if you look at all these scary words and you look at that scary picture on the right-hand side, that really is disconcerting. It invokes fear. But the reality is, well, if somebody my age has almost all of these, I think I do have all of these, but I don't have back pain right now. And so to equate my future back pain with any of these is probably inappropriate. And one way that one study that really interestingly showed this and showed the power of the language of an MRI report was when they randomized MRI findings to both patients and clinicians. And some of them were just anatomical descriptions, like I talked about with this scary language. And the other one was more of a context-specific description, meaning this is normal age-related changes, explaining things in a more palatable way as compared to the catastrophizing and the low self-efficacy and bottom line worse outcomes that we're seeing when these anatomical descriptions on MRI were shown. And this was with patients, but interestingly enough, similar things happened with clinicians as well. So that when they saw those anatomically based, degenerative disc disease, they perceived greater severity and they perceived a need for more invasive intervention. And again, these are the same findings from the same MRI report, but just worded differently and presented in different context. And again, to help drive home that point of how imaging can be harmful are these 4 studies. The first block is actually 2 randomized trials. One was just randomizing people to get an MRI or not. One was just to get a plain film X-ray or not. But the outcomes were very similar, which those who had inappropriate imaging early on had lower self-perceived health status, higher persistent pain, higher number of visits. The second study was a workers' comp study. And inappropriate early MRI led to strong iatrogenic effect, no benefit, worse outcomes, more disability, an average of $13,000 in higher medical costs just from inappropriate imaging. And then the bottom study, if I haven't gotten your attention yet, maybe the Kendrick study in the British Medical Journal will, and that is where they took these kind of MRI reports and showed them to people in waiting rooms who didn't have back pain. They were there for other reasons and said, if this was your MRI, do you think you would need surgery, even if you didn't have symptoms? And half of them said yes. So what we've done only in Rochester so far, and we really need your help to see if we can bring this to the rest of upstate, is that we embedded epidemiological chart into MRI reports. So it's not this chart, but it's a more simplified one. But the idea being that they're age related, and you could see, if you're 60 years old, 88% of healthy individuals who don't have back pain have degenerative disc disease, or 2/3 have disc bulging, half have facet degeneration. If you know that you have this type of pain syndrome, then you know that you. If you know you have these kind of anatomical changes, then the pain is not as scary to you. And so lo and behold, what happened when we embedded that, and again, we published this in the Joint Commission Journal of Quality and Patient Safety with Dartmouth, and we found $330 in downstream savings just from embedding that. That was just a no-cost intervention to anyone, but that's how much fear we were able to diminish from the language by just choosing that. So any of you who are interested in doing this with your radiology groups in the upstate area, please let me know. I'll be more than happy to share with you and see if I can support you in that. Real quickly, I mentioned this term neuroplasticity, but again, it's an important concept to understand with back pain, neck pain, chronic pain in general, because we are meant to be habit forming. Half of your day is done rotely by habit. When you brush your teeth in the morning, there's a ton of fine motor skills there, and you don't even think about it because you've got it to that pattern level. So, but that affinity for patterns helps us cope through life, but it also helps create chronic back pain. And those things are fed by time, too much time and fear and pain and inactivity, the things that Bob went through at the beginning. But we can rewire that. Cognitive behavioral therapy, graduated activity, and graduated exposure are ways to help to rewire chronic back pain patients. And just a couple quick studies just to get your attention to on the opioid issue. This study in pediatrics found that if you took healthy adolescents and you gave them an opioid for wisdom tooth extraction or a sprained ankle at the game, lo and behold, even though these folks had no history of drug use, that they were 30% more likely to risk future opioid misuse. In other words, we're almost pre-programming their brain to seek opioids. This is a powerful medication that isn't that powerful at decreasing pain, but it's powerful at creating havoc. And to remind you that mindfulness and meditation is always a good option. If you can engage the patient in these things, it uses a different pathway. And so whatever that individual is doing for pain, whether it's a medication or not, to encourage them in the use of mindfulness and meditation is always an important issue. Also, other things we have to start thinking about are, and this came up with our conversation with Consumer Reports, and this is their survey, when they were interviewing me, and they said, well, how come as an insurer you don't pay, or you pay spottingly for the things at the top of this chart, but at the bottom, those more expensive things, you don't? And my only honest answer I have is we're in a culture change right now, and we have to figure out how do we get more people to engage in yoga and Tai Chi and conservative therapy early on, because that is the most cost-effective way, and it's the thing that people choose the most often. So what we've been doing is building an app. This actually, again, started with Consumer Reports. After that interview, I kind of pitched the idea to them that, gee, what society needs is a patient decision guide to help them decide, do I need care? And if I need care, should it be self-care? Or if it's not self-care, how do I go through the system and get as good a care as I can get? What questions should I ask? Who should I see? What's my understanding of going in there? Should I be demanding an MRI? Should I be asking for an opioid? And educational processes before they go, so that they can go in there as educated and informed individuals and ask the right questions. And then, going through optimal care, as they come out of care, the secret sauce of the app is we want to engage people, everyone, to go to this self-care arena. And I say that because the things that treat back pain and the things that prevent back pain are things like, activity, exercise, good posture, but also things like anti-inflammatory diets, eating more vegetables, being more mindful to manage your pain, getting a good night's sleep, meaningful relationship, quitting smoking, losing weight. All of those things have direct impact on back pain, and lo and behold, they impact many of our other cost drivers. And another component of this app that I think is really intriguing is our ability to collect patient-reported outcome measures from individuals. And here, if we're going to start addressing these things as a community, to get community-level data, and this is what we're hoping to do in Binghamton, and we're hoping to bring to other communities of interest across the state, is can we look at the community as a whole? Can we see what healthy people are doing and what unhealthy people are doing and learn from that? And can we engage them earlier and more accurately, so that their outcomes are more efficient and more effective? Because those things that I mentioned that treat back pain also impact most other musculoskeletal disorders, as well as diabetes and heart disease and falls and depression and some forms of cancer. I mean, you can go right down the list of many of our chronic diseases, and activity and mindfulness and eating better and getting good sleep and all of those things impact those. The difference with back pain is that the pain gives you a teachable moment. So you don't have those kind of painful teachable moments with diabetes or high blood pressure. They're silent until they get really downstream. And we want to address things upstream as much as we can. So can we use that teachable moment of back pain to get more lifestyle engagement, so that not only can we help to get them through their issue of back pain quicker and show them how they can improve the odds of not having flare-ups, but also it's kind of a backdoor way to engaging them to treat so many of our other chronic health conditions. We need to do this through technologies. I think I mentioned that we put all of our trainings online now, and this idea of telemedicine and PT at home, and you're seeing monitoring care with wearables. This is all going to be part of the future, and we really want to make sure that we are staying on top of those things and engaging in such a way that we can optimize the care of our communities. So, can we, through our trainings, really use that motivational language, and even if it's a telemedicine visit, can we show how many things can be done in the musculoskeletal world without hands-on care? Certainly hands-on is certainly necessary at times, but it is not always necessary. But having the right practitioner giving the right advice at the right time is really, really key here. And then, some of the virtual physical therapy data that's coming out is really intriguing. It seems to be, especially up in your area where there's a lot of rural folks who don't want to drive, 20 or 30 minutes to go to a physical therapist 3 times a week in the snow with crutches. Are there ways that we can have that practitioner encourage that patient from home, and are there simple apps that can be used? And they're out there, and we'll be bringing those forward. And as we bring these ideas to the community, we are really striving to do that in the context of relational coordination, meaning that we identify shared goals, shared knowledge, mutual respect, and we communicate in a timely, frequent, accurate, and problem-solving way. So going back to Bob, I don't want this to come across as it's always the provider's fault. We as the insurers are playing a role here. I know. Do we have too high copays in some areas? Are there financial barriers? Are we delaying access? We're looking at these things. We're trying to bring efficiencies. We know that the fee-for-service world is the wrong kind of incentive, and we're trying to work with your teams as best we can to come up with value-driven approaches. It's challenging. Sometimes hospitals, especially through the COVID years, are really struggling, and sometimes there's an encouragement of, we don't really want less MRIs or procedures done because we have to make our bottom line, or they discourage leakage even though a provider outside of their system may be more efficient or more effective. We have to understand the rationale that they're coming from, and respect it and work with them. And the employer groups, that they need to know too, that if they say you can't come back to work unless you're 100%, or they have high risk environments, or they have low job satisfaction, that they too are part of the problem that's creating chronic back pain. So remember this study that I referenced earlier, that we're delivering too little care that's most needed, and we're delivering it too late. And again, the education, childcare, community safety, housing, nutrition, transportation. These are all community-based issues. And so as we start to wrap up here, I wanted to just reinforce what so many of you know, and that is that there's really an opportunity for community-based health. We need to address these things sooner. And I'd like you to explore back pain as one of those initiatives. I like to paraphrase Tip O'Neill, for those of you who are old enough to remember, this rather flamboyant, articulate Speaker of the House of Representatives, who famously coined a term that all politics is local. I like to kind of tweak that and say all healthcare is local. People, whether they're rural or urban, want to have a healthcare system for people of their community that look like me, that I know, that I trust, and that has resources of my community going forward. And that means that we have to have local data of your community to really start to create the level of community-wide engagement that we need, and stakeholder engagement. And then by doing that, then can we start measuring and caring for what's really most important to the community, and start streamlining best practices and stakeholder engagement, and really to start to change the norm, the cultural norms of health within our communities. So what if all providers are on the same best evidence care pathway? What if all the stakeholders were all supporting the same patient active approach? What if we had this kind of app that helped the individual decide, does this person need to become a patient? And what if that app could collect promise data or patient-reported outcomes that would really help to create a big data set that would let us know where the issues are within our community, and have the individual give the ability to share that data with providers or payers, employers at their discretion. can the community come together and dispel some of those myths that you often see, that you should get an MRI to see what's going on, or opioids work really well, or boy, you need a surgeon to fix that. Again, all of those are sometimes appropriate, but they are all being overutilized right now. And can we use that teachable moment of back pain to trigger best evidence self-care, and to really impact, from our perspective, the big cost drivers, certainly the chronic diseases of your community. So any community that jumps into this, obviously these bullets are pretty self-explanatory, but the interesting thing too is the ability to use community-based organizations and engaging volunteers in activity levels that would help teach these and encourage these kind of life-changing behaviors. And the irony here is that, one of the things that really trigger the happiness in an individual's life and help to fight depression is volunteering, is helping others. And so there are many people in your community that want to help others, but don't know how to do that. Can we create an ability to start connecting those volunteers to your community-based organizations and other approaches that let them participate in the health of the community as well? And then by doing this, there are research and grant opportunities for early adopting communities who might want to engage in this. So I think that's just something that you might want to explore. And again, I'll be glad to help. So I'm just going to close up where just saying that if you want to brainstorm on this, I'm really engaged personally on creating collaboratives, understanding that when you look at any problem from just the perspective of one stakeholder, you're really missing it. It's just like diversity in your workplace. We need to use collaboratives in our communities to really understand the problem from all sides, to bring that diversity of perspective and knowledge forward. And then the synergy that evolves and the power that comes and the momentum that comes out of those kind of relationships is really key. And so can we get good data, and can we find out where health is arising from, or where is it being impeded in our communities? Can we collaborate with stakeholders, all of them, to identify and implement best approaches and not just abdicate it to the healthcare system per se? And then, so is there a think or an action tank that regionally, some people want to put together? This is what we're doing in Binghamton, and I'd just like you to kind of explore that and see if you're intrigued with that in some of the other areas of upstate. So if you are, let's see if you can identify key stakeholders and resources, and what are gaps in the community and data. And this is what we're going through right now, as we're trying to ferret this kind of modeling out in Binghamton. And I think you can see how it's a bit challenging, but the excitement for it and the buy-in has been really good. So I'm really hoping that we have a model that we're going to be able to replicate and bring forward to you very soon. So let me just finish up by just going back to Bob and Gary. So now Bob has another bad episode of back pain, and guess what? He's still out of work and still not doing too well, but it's never too late for Bob. If the practitioner will really address his fear and inactivity, so that he has less chronic pain through education, through language, through graduated exposure, graduated activity, motivation, maybe medically assisted treatment if he's been on opioids, and his ability to create mindfulness. And what about Gary? Well, Gary didn't come back, even though Gary had a flare of back pain at the same time his twin brother Bob did. But now he went through the pathway, he went through a practitioner, he was taught what to do, he tries his own self-care approaches, and lo and behold, he got through it without having to enter the healthcare system. And lo and behold, maybe his blood pressure, maybe his cholesterol, maybe his diabetes and his depression are more under control. When you have understanding and activity, you're more apt to have a quicker recovery and more self-care, and this tremendously safe spillover to address so many of our chronic pain initiatives. So thank you very much. I left a few minutes for some questions if we have them, and I'll be glad to chat with anyone who's interested.
Thank you so much, Brian. That was awesome. If you actually want to just go back to that slide, it did have your email on it, and want to stress to our participants, that this was a really awesome presentation and an opportunity if you do want to connect with Brian. Just want to invite everyone to take note
All
of
right.
that. No problem, Brian.
Yeah, it's
We don't
just my name, brian.justice@excellus.com. So feel free to email me. I'd be more than happy to follow up with you.
So no questions in the chat. Brian, if you want to just check on your end in case anyone privately chatted you.
No, I think we're okay.
Okay, great. Well, honestly, so amazing. I think you covered everything, and that might be why we have a quiet group. But I want to thank everyone for joining us today for Brian's presentation. And thank you again, Brian, for taking the time out of your schedule to join us for our summit. Everyone, this is the last day of the Leadership Summit, and we hope to see you at our next session at 12 p.m. Thank you again, everyone, and have a wonderful day.
Thanks, everyone.